My name is Deepak Ganesan. I'm a professor of computer science at UMass Amherst, and I'm one of the co-PIs of MassAITC. Our first speaker is Dr. Martin Sliwinski, who comes here from Penn State. So he's the director of the Center for Healthy Aging at Penn State University and one of the leading voices in cognitive aging and dementia prevention. And he's pioneered mobile real-world monitoring of cognitive function, unlocking new ways to detect and understand early cognitive decline. So please join me in welcoming Marty Sliwinski.
Thank you very much. I'm really grateful to have this opportunity to share with you some of the work I and my colleagues in other groups have been doing that utilize mobile technology to improve how we can measure and monitor cognitive change, especially in the context of Alzheimer's disease and dementia prevention. So what we're doing goes beyond simply trying to digitize conventional neuropsychological tests for mobile administration. Instead, we're rethinking how, when, and where to monitor and measure cognitive function by embedding ultra-brief assessments in the context of people's everyday lives so we can identify and monitor fluctuations, variability, and change as they unfold. After I share with you and describe our general approach and the rationale, I'll share with you some examples that illustrate what this approach looks like in practice. But before we get there, here are a few takeaways I want to leave you with. The first is that by measuring cognitive function much more frequently than is typical with neuropsychological assessment, we can uncover some short-term dynamics and processes that can help improve the sensitivity for detecting very, very early impairment. Secondly, if we use repeated assessments and embed those in long-term longitudinal studies, that allows us to zoom in to examine fast-acting processes like variability and learning, and then zoom back out and use those to help us elucidate and explain long-term changes in cognitive function. And because our assessments are embedded in the context of everyday life, this affords the possibility of relating ups and downs in cognitive function to everyday kinds of exposure, stress, fatigue, pain, and the like, which opens the door to more responsive and personalized models of cognitive health. So most of the work in dementia focuses on these phases when people are exhibiting clinically detectable impairment, either diagnosable or milder forms of impairment like MCI. What I'll be talking to you about is work that occurs in this space in the pre-symptomatic or preclinical phase, which is when people are not yet symptomatic or impaired, but maybe already experiencing physiological changes at the very early stages of disease. So traditional neuropsychological testing has been most helpful in discriminating between individuals who are and who are not impaired. That is not the task that we face when we're studying the very early pre-symptomatic phases. What we're interested in trying to do is not to differentiate between people who are and aren't impaired, but to detect change within individuals over time. So this is made complicated by the fact that cognitive change occurs across different timescales. The solid black line there signifies what we're typically interested in, which is long-term change that's manifest over the course of years, maybe longer, that might be driven by biological aging or neurodegeneration. But we often ignore faster acting processes that operate at a shorter cadence, as depicted by the green line, which is variation that can occur over the course of months or weeks. And we can even drill down to a finer time scale to look at variation across days, hours within days, or even faster time scales than that. Now, you might say, well, I'm only interested really in these long-term changes driven by neurodegeneration. Can I ignore the other types of variation? Well, you can, but then you risk committing what we refer to as temporal sampling error, where fast-acting processes can obscure the pattern of change observed over slower timescales. So a person could have a bad day, and that could appear that they're declining, or they could have an exceptionally good day, which could mask real change. So our approach has been to try and improve on this by aligning our assessments with the dynamic and context-specific nature of cognitive performance. So how do we do this? What's our solution? We embed ultra-brief cognitive assessments into ambulatory research protocols like ecological momentary assessments, EMAs, which involve high-frequency administration. So we may measure people instead of in a single clinic visit or a single session over the course of a few days or even a few weeks. And they may get assessments once a day or very, very brief assessments multiple times per day, paired with contextual data obtained through self-report or other wearable sensors. And this allows us to examine different kinds of performance dynamics, which I'll talk about in a moment. But before I get there, I just want to show you what some of our assessments look like and how they're designed. This is an example of one of our mobile tests, which are designed to be very, very brief. We can administer them in less than a minute, and they tap core cognitive abilities. This is a measure of processing speed where people have to tap as quickly and accurately as possible. One of the tiles on the bottom that matches an exemplar on the top. We measure spatial working memory by presenting, for example, 3 dots in a grid, followed by a distractor, and then people have to tap and recall their location. And then we have a test of short-term visual binding, which has been shown to be very sensitive to familial Alzheimer's disease, where basically you have to determine whether or not the colors of shapes have changed from one trial to the next. So the main point here is that these are designed to be very intuitive because these are not proctored exams, so people have to really understand what they're doing. What kind of data do we get by administering these tests repeatedly over an extended period of time? Well, we get data that looks like this. This is data from one participant from the Einstein aging study. I don't know exactly who they are, but I know they're over the age of 70 and they're not demented. This is a response time task, so the decreasing means people are getting better across repeated administrations. What you should recognize from this is that there is not a single score that characterizes the person's performance. There are dynamic properties, such as the speed up in performance, particularly early in the data stream. Then you can look at the variation in time-to-time assessments. Each one of those dots takes about 35 to 45 seconds to collect. So this is under an hour distributed across 2 weeks, part of a research study. But then we can also drill down to the patterning of variation, the ups and downs, and relate those to time-varying processes and exposures such as social engagement, physical activity, and stress to see how these travel together over time. So I'm going to be giving you a couple examples that focus on these aspects of the dynamics. So the first example doesn't come from our group, but comes from work that Kate Papp and her team at Brigham and Women's Hospital has done. And this is a really, really important study. What they were interested in determining is whether or not repeated brief testing distributed across 7 days could distinguish between people who were biomarker positive and negative for Alzheimer's disease, but who were otherwise asymptomatic. And what they found really is remarkable. On the first assessment of performance from their app or from the clinical gold standards, there is no difference between the biomarker positive and negative individuals. But over the course of the repeated testing, you can visually see that the biomarker positive group did not benefit from the repeated testing as much, didn't learn as rapidly or to an extent as the people who were biomarker negative. So what this says is that multi-day testing reveals performance characteristics that can discriminate status, biomarker status, that would not be detectable by conventional types of testing approaches. So the next example comes from our team, where we basically did the same kind of thing that Kate did, only we repeated those bursts of assessment across a follow-up period, repeated them every year. And this is part of the Einstein aging study. These are individuals who were over the age of 70. We did this in a few hundred people. None of them are demented, but some people do have the mild stages of cognitive impairment. So this is data from one of the individuals. We did this over 4 years, so we have 5 measurement bursts. This is just the first 2 multi-day measurement bursts. And the point here is that we can see different types of processes that are operating over different time scales. So it isn't just that individuals' performance is getting better or worse. It reflects a mixture or a combination of processes that operate across different time scales. Here we see speed up across days within a measurement burst, but then we need to tease that apart from long-term change, and we do that by applying a computational model. a computational learning model. We don't have to get into the specifics of that, but what that allows us to do is distinguish between the improvement occurring across days and decrements in asymptotic or best performance across the long-term follow-up. And then we can look at the parameters to extract a key feature that we typically don't look at in longitudinal studies, which is forgetting that transpires over that 1-year period. This may seem overly complicated, but this is depicting a phenomena we've all experienced. When I moved to Syracuse, I took up cross-country skiing. I got better and better during my first season. The snow melted. I stopped skiing, came back the next season. I did not pick up where I left off. I wasn't quite as good as I was when I left off, but that did not reflect a decrement or a decline in my skiing ability. I just lost some of the gains I had accumulated previously. That might also be the case here, and we're able to tease this apart. When we applied this to data from real individuals, and we're just showing a few examples of individuals from the first 2 measurement bursts, we see this does a pretty good job of fitting their data, and we explain between 60 and 80% of the variation in the data. But then what's really interesting is when we look at the average curves across the 4-year follow-up period, and we break this apart by people who are unimpaired versus individuals who are mildly cognitively impaired. And what do we see? First, what we see is that their asymptotic performance, their slowing is, their fastest performance is becoming slower over the course of the follow-up period, right? And this is what you would expect in 70 and 80-year-olds due to aging. But what is interesting is that there's no difference in the rate of slowing between the people with and without MCI. So it's not like the folks with mild cognitive impairment are experiencing accelerated slowing, but they do differ from the other group in ways that we can discern by applying this kind of computational model to discriminate these multi-timescale processes. It's difficult to see, but they learned at a slower rate. So the slopes are not as steep, but what's really interesting is that the people with MCI exhibited more forgetting from one burst to the next, meaning that they did not retain the benefits of having practiced at these tasks previously. So if we had done a typical longitudinal study where we had just measured people once every year, either we would have found no difference, or we would have mistaken the difference between MCI and non-MCI people as one group slowing down. So what the takeaway here is that this allows us to be able to distinguish between these different processes occurring at different timescales. The very last example is intended to illustrate the fact that we can not only track variation in cognitive function over these fast timescales, but we can link that variability in cognitive function to other types of processes. Such as social engagement, physical activity, psychological states like stress, or physiological measurements. So we can examine how cognition and these other processes are coupled over time in this short time scale. One interesting example also comes from the Einstein aging study, where we administered these tests coupled with self-reports on social activity. And these were people who were not cognitively impaired. And what we found is that on days where people reported more positive and more frequent social interactions, that their cognition was boosted on that day, and that boosting effect persisted for 1 to 2 days after those periods or those bouts of social engagement. So we evaluated Granger causality, and we showed this was directional. The other interesting feature is that this benefit was most pronounced in people who were most socially isolated. So this is interesting because this suggests that we can use these techniques for faster monitoring of intervention effects, examining cognitive safety and how these could unfold over time. So this is not just a fluke. We and other groups have used these types of procedures to show that day-to-day, moment-to-moment, and across hour variation in cognition is associated with factors like stress, with loneliness, with time of day, with physical activity, and glucose fluctuations in diabetics. And what's really remarkable is the magnitude of this variability. So this is not just noise, this is systematic variation. So when we compare one day versus the next, And on that one day, it's a no stress day versus a high stress day, or a low physical activity day with a high physical activity day. That difference across days is equivalent to about 2 to 5 years of cognitive aging. So what we're seeing here is that this short-term variation is meaningful, is large, and can be linked to modifiable factors, contextual factors that occur in everyday life, raising the possibility of using this again for evaluating interventions in ways that we never have before. So those are the examples. So let's revisit some of the takeaway messages. So first, there we go. So the first one is that we need to think of cognition as being more than a score. Typical neuropsychological assessment thinks of tests we administer to an individual once, and we get a score, and this can characterize their memory or their attention. What we see is that there are more dynamic features that carry with them information that can be useful clinically and useful prognostically. So there are some opportunities and needs in this area. I think there's great opportunity for developing computational methods that can help extract this information. So new ways of thinking about adaptive testing. We all know what adaptive testing is, right? This is what they use for the GREs or the SATs. And this operates as sort of determining what question in a test to ask right now to discriminate you from someone else. I think psychometrics 2.0 will be a different kind of adaptive testing, as when do we need to measure an individual to provide the most information about whether they're changing or not in a way to minimize burden and maximize precision. The second takeaway has to do with connecting across different timescales. Often, if we only measure at the frequency we expect or are interested in seeing change, and we ignore processes that occur at different timescales. So I think we can do a better job of emphasizing and designing studies that include high-frequency assessments, even if we're just interested in looking across longer timescales. But there's a problem with this, right? So people are very adherent to these types of protocols, even though they're demanding in a research setting. But how scalable is this? Can we get people to be doing these types of intensive measurements for extended periods of time? We can if we pay them, but that isn't always what we're interested in doing. So I think we need to think about how we can pair these active cognitive assessments, which are valid and highly precise, with passive data streams collected through sensing that could have to do with measure driving or measure interactions with screens and computers, so we can co-validate those measures and maybe integrate them in a way that could take us to sort of a more real-time and precise and scalable approach to monitoring brain health. So these were the takeaway messages, and I'm hoping to hear some ideas about how to take this kind of research to the next step. If you're interested in any of what I've talked about, this work has been funded by the National Institute of Aging. We have a platform that's very extensible, interoperable, completely open source. So I'd invite you to visit our GitHub or reach out to us if you're interested in collaborating. Our platform works with commercial software, and we could talk about that a little bit more. But for now, I'd also like to thank my collaborators that made this research possible, the funding from the National Institute of Aging, which was vital in doing this, and to thank all of you for your time and attention.